So
good evening, everyone. Welcome to the master class. This is the second master class from the master teacher, Dr. A. Muruganathan. And all of you know that hypertension has been a big problem in Indian society. Many people are undetected, many have the complications, and in the process of detection and diagnosing a patient from the different presentations, controlling the blood pressure and going further makes a big challenge for all the physicians around. And Dr. Muruganathan has been an instrument in creating awareness among all the physicians, the public as a whole, and the medical fraternity regarding the dangers, regarding the approach, regarding the treatment, and what we see for last 3 long decades he has been working. So it's a privilege listening him on this important topic, and the program is hosted by World Lung Foundation South Asia, and World Lung Foundation is ASIA's major aim and objectives include the areas of public health ranging from cardiovascular disease control and prevention to the road safety to environmental health to civil registration and vital statistics. All public health related activities and the scope of the work cover comprehensive public health services. You listened the program, and there was a very good interaction last program, I remember, and the whole Medical Academy of India has collaborated, and whole Medical Academy stands to conduct seminars in general medicine, particularly diabetes, cardiology, hypertension, lipids, obesity, and the allied disciplines, and thereby improve the medical knowledge to medical practitioners and specialists, to arrange for research in internal medicine and related specialties, and to run institutions in further run to further of trust, to educate the public on the prevention of diseases and maintenance of the good and the sound health. And this has been led by none other than Dr. Muruganathan, and then a team across the length and breadth of the country are there. We tell Dr. Muruganathan's army who are into this awareness campaign, and then each and every physician takes this as a priority in learning and disseminating the knowledge. So objective of this webinar series is to promote the standardized care for hypertension that is evidence-based and aligned with international best practices. And the focus of the virtual workshop would be to promote standardized care for hypertension based on recent WHO Hypertension Treatment Guidelines 2021, to promote the opportunistic screening of all patients over the age of 18, to reduce the physician inertia to start and continue treatment of hypertension, to emphasize the importance of the medication titration and follow-up hypertensive patients to ensure better blood pressure control. So all of you know the importance of the topic and importance of the theme. Without much delay, I'm just briefing you about the detailed agenda of the program. So all who will be participating, can we go back? All who will be participating will get a participation certificate from the World Lung Foundation South Asia and the whole Medical Academy of India, and also get the credit points from the Tamil Nadu Medical Council. That's a very important part of it. And we have speakers like Dr. Muruganathan, Dr. Bidita Khandelwal, and the different programs which are spreading throughout the series are the 23rd August 9 to 10:30 we had Dr. Cheniappan, cardiologist, and today Dr. Muruganathan will be speaking on difficult to treat hypertension. So the presentation will be followed by a Kahoot.in quiz, And the steps for quiz program after the main talk by Dr. Muruganathan, I'm briefing for you. And all are acquainted about Kahoot. It's a very scientific way of assessing and giving you marks, and there are interesting prizes. You have to type the Kahoot.in in your laptop or mobile, and you have to be ready. We'll give you the game pin number. Please enter the pin and your name, and then you can there are 13 questions. For each question you have to answer, and the answer you can get from the presentation of our master teacher, Dr. Muruganathan. Those who give correct answer early will get more marks, and we will give blood pressure monitor to top 3 podium winners. So that is in brief about the program. And today we have Dr. R. Rajashekhar as the panelist. He has been a master teacher, and he has been the FICP, FACP, FRCP, Glasgow, and FISC, and he runs the Anai Abhirami Medical Center. And the most important thing, at his age, he disseminates knowledge throughout the country in the different WhatsApp CME groups. He is at present the treasurer of ACP India chapter, the past governing council member of API, and editor of My Mnemonics in Medicine 2017 and 2018, a very essential book I have recommended to my postgraduates. He has written a monograph on anemia in 2017, sub-editor of Progress in Medicine 2017, and delivered many talks in the state and national conferences like API, IMA, and RSSDI. He has written more than 100 articles, and a very active physician who has worked throughout the COVID period and thereafter, updating the knowledge of every physician whom the whole country knows. And the most important is you're listening to Dr. Muruganathan, and the next webinar of the series is on 20th September at 9 p.m. where again we have Dr. T. Geeta as speaker, and Dr. Muruganathan himself will moderate, and Dr. Meenakshi Dhar is the panelist. Today, Dr. Rajashekhar is the panelist, and then I'm the moderator, and Dr. Muruganathan will be the speaker. So to introduce Dr. Muruganathan in brief, can I have his CV, Dr. Muruganathan?
Not necessary, not necessary.
Yeah, actually, all of you know Dr. Muruganathan, and he has been the past president of API, past dean of ICP, Indian College of Physicians, and past governor of ACP, the American College of Physicians, and a academician, a devoted administrator who works throughout the country across the length and breadth to create the knowledge, the awareness, and the update every physician in the science who first started the CME and made hypertension a big focus across. Will listen him, and I have the pleasure of presenting you all Dr. Muruganathan, and followed by that we'll take questions. So that is what I want to tell. And again, I announce the Hold Medicon 2022 on 17th and 18th September, 17th afternoon and 18th afternoon. You can join this, and we have very interesting program on this Hold Medicon for you with faculties all across the country.
We have international speakers also.
We have international speakers, we have national speakers, and we have very interesting topics chosen as per your requirement. So I request all of you to take the advantage of this Hold Medicon Academy, and that it is not very far, and you'll block your date to attend the program. With this, I welcome all of you. We have more than 150 people who have joined the discussion, and many are watching in the social media. So I request Dr. Rajashekhar to be ready with the panel for the panel discussion, and with this inviting all our faculties, all our attendees, all our organizers, we present you Dr. A. Muruganathan for the topic difficult to control hypertension. When you come across a patient with hypertension, you measure, you establish, then you start 1 drug, 2 drug, 3 drug and try to control. So there will be a class of people who will not be easily controlled, and they require multiple drugs. They require the other risk factor reduction, and at times surgeries, which Dr. Muruganathan will discuss. Followed by that, we'll take questions and discuss with the panelists to take up all your queries. It's time, sir, for you to start the presentation, Dr. Muruganathan.
Thank you so much, my brother Dr. Jayant Panda, and then my panelists again, my good brother Rajshekhar, Sangram brother, Vidita Kandulwal, and all my dear brothers and sisters to join this webinar. The plan will be introduction and what is difficult to control hypertension, why does it occur, what is pseudo resistance, how to identify the cause and how to manage, and some takeaways. Shatak lecture was an interesting lecture. He says the hypertension paradox, more uncontrolled disease despite improved therapy. If you see more, the number of people with uncontrolled blood pressure is increasing despite the therapeutic advances. There are a lot of terminology. What is uncontrolled hypertension? What is apparent resistant hypertension? What is pseudo-resistant hypertension? What is true resistant hypertension? What is controlled resistant hypertension? And what is refractory hypertension? No, the WHO recommendation, the initiation of pharmacological antihypertensive treatment with a confirmed diagnosis of hypertension and systolic blood pressure of more than 140. If there is a comorbidity, systolic blood pressure of 130 to 139. Any difficulty in achieving this target is called difficult to control hypertension. Any BP which is out of target with 1 or 2, 3 drugs is called uncontrolled hypertension. For example, if somebody is taking 2 drugs and the blood pressure is not under the target, then this is called uncontrolled hypertension. What is apparent resistant hypertension? Is defined as a blood pressure that remains above the goal in spite of concurrent use of 3 antihypertensive agents. One of these agents should be a diuretic, and all agents should be prescribed at maximum recommended antihypertensive dose. You must use 3 drugs. One should be diuretic, and all the drugs should be the optimal dose. And even after that, if you don't get the control, that is called resistant hypertension. Among patients with apparent resistance, true resistance is distinguished from pseudo resistance. Patients whose blood pressure is controlled with 4 or more medications should also be considered as controlled resistant hypertension. So one is resistant hypertension. If the blood pressure is controlled with 4 drugs, then it is called controlled resistant hypertension. You can see when the patient is on 1 to 2, 3 drugs, BP at not target, then it's uncontrolled. When you use 3 drugs with the diuretic with optimum dose, BP not at target, it is called apparent resistant hypertension. You always should rule out pseudo-resistant hypertension and the BP at not at target. True resistant hypertension when the BP is controlled with 4 drugs. If the BP is not controlled even with 5 or more drugs, it is called refractory hypertension. So these are the terminologies which we use in difficult to control hypertension. I already told you 1 to 2 not controlled is uncontrolled. If the 3 not controlled, it is resistant hypertension. If it's 4, if it is controlled, it's controlled resistant hypertension. If even after 5, if there is no control, it's called refractory hypertension. So these are the terminologies which we use. You must understand in difficult to control hypertension. Refractory hypertension was defined as the inability to achieve blood pressure control despite maximum tolerated dose of at least 5 antihypertensive medications, including a diuretic chlorthalidone and spironolactone. The patients with refractory hypertension achieved mean office blood pressure of 178 by 103 despite average of 6 antihypertensive medications. Based upon the persistently higher heart rates and lack of response to intensive diuretic therapy among patients with refractory hypertension, the authors suggest that treatment failure in such patients may be due to neurological mechanism. In a refractory hypertension, The basic neurological pathological mechanism is sympathetic overactivity. It contrasts to the conventional resistant hypertension, where there is a persistent hypervolemia. So, resistant hypertension is hypervolemia, refractory hypertension, sympathetic overactivity. Now you can see non-adherence and drug-related causes 74% of the resistant hypertension or difficult to treat hypertension. So non-adherence and drug-related causes. I'll come to one by one. Among the resistant hypertension, which is 21%, uncontrolled resistant hypertension is 32%, which means with 3 drugs, it is not controlled. Whereas controlled resistant hypertension with 4 drugs is 65% and 3% is in refractory hypertension. And this is the age-wise distribution of resistant hypertension. You see 40.5% of them are between 46 to 55. And 18 to 25, you see 40%. So major chunk of persons are from 18 to 25 and 46 to 55. Then what is the why you should have resistant control the hypertension? When you don't control the hypertension, the resistant hypertension can first lead to heart failure is more 1.37 hazard ratio, followed by CV mortality, IHD, stroke. So heart failure is the main thing, first complication. Then I come to pseudo-resistant hypertension or pseudo-resistant causes. The pseudo-resistant causes can be doctor-related, patient-related, drug-related. So pseudo-resistance can be of all the 3, doctor, patient, and drugs. I'll come to one by one. What is doctor-related? Inaccurate measurement. We had been talking so many times of how to measure the blood pressure. And if you do inaccurately, that is one of the cause for pseudo-resistance. Especially nowadays, I don't want to see any such stool in a clinic. You should not measure blood pressure asking the patient to sit on the stool. Then what is pseudo-hypertension? Oscillus manual. The oscillus manual is in an elderly person. When the systolic blood pressure is pumped more than, when you pump the BP more than systolic blood pressure, even then the artery is not collapsed. It feels like a cord. That is because of the thickening of the vessel. So this is called oscillus manual. If the oscillus manual is positive, is again pseudo-resistance, especially in elderly hypertension, elderly patients. The physician's inertia, we had been talking frequently about inertia. If you see, when the blood pressure is 140, 149, 150, 159, only 23% of the physicians aggressively treat. Otherwise, they say, okay, chalo, we'll see next time. So you should not, be complacent. Where even if it is 149, you should treat aggressively. So 23% only treat. If you see even 170, 179, only 28% people treat aggressively. The treatment inertia is defined as the failure to increase the dose of a medication or add another medication when blood pressure is not under control. The possible reasons, the doctor may not notice the high BP recording due to busy, crowded clinics. BP readings are borderline high. They'll pass it as borderline high. The doctor suspects the patient may have missed the medication. A patient might have reported adverse effects, change medication to a different class, and reluctance to use combination therapy. We must use combination therapy. Now, all the guidelines last time I told you, start combination therapy even in the first visit. Then the clinical inertia is again divided to physician factor, patient factor, and office system factor. Last week I elaborated on this. Now, compliance or adherence. Only up to 2/3 of patients take at least 75% of the prescribed antihypertensive medicine. There was a study for 1 year. If you see how many people take diuretics, only 38% takes, and 58% takes only ACE inhibitor. 64% only they take ARB. So ARB is more complex. More people use without any problem. At least ARB only one year, full year, 64%. But diuretics they discontinue after 38% only use. The 62% discontinue before 3 or 4 months. Then treatment adherence I already told you last time, and the non-adherence is the cause for pseudo-resistance. It can be there. I told you it is again. We elaborated in the first part what are the causes of the non-adherence, reducing polypharmacy, once daily dosing over multiple times per day, and home BP monitoring is very important to reduce adherence, to improve adherence. reminder packaging medication, etc. Now, coming to the, suppose if you don't take the medicine, what are the problems? I already told you. And if you see the statistics, male gender compared to female does not adhere, 1.19. Surprisingly, young age people also do not adhere. Whereas diabetic patient, if you see hazard ratio 0.77, somebody with diabetes, the adherence rate is better. So the first prescription never purchased by 1% of people, and 14% discontinued after first prescription. Then drug-related causes. I always say seven I's. Drug-related causes, 7 I's. What are the 7 I's? Improper selection, inadequate dose, improper combination, improper timing of medications, inadequate absorption, inability to give 24 hours protection, intolerable side effects. These are the drug causes of pseudo-resistance. And of course, all of you know, white coat hypertension also is one of the cause of pseudo-resistance. Blood pressure 140/90 when measured in the office, or we say clinic, when measured in the clinic, and normal daytime ambulatory blood pressure of less than 135/85. The risks are less than that of sustained hypertension, probably small risk when compared with people with normal blood pressure, possibly a precursor of hypertension. In white coat hypertension, organ damage is not there. If the organ damage is there with blood pressure more in the house than the clinic, it is called masked hypertension. All of you know about this normotensive white coat, clinical eye, home BP is normal. Whereas masked hypertension, clinic is normal and home is high. Now, these are the causes of pseudo-resistance. I already told you. To summarize, doctor, patient, and drug. Doctor is improper measurement and then inappropriate combination, physician's inertia. Drug, I already told you, 7 I's. Now, coming to the true resistant hypertension. Having talked about pseudo-resistance, we come to true resistance. The true resistant causes are, there are two types of causes. One is specific cause, other is secondary causes. The older age, high baseline blood pressure, obesity, excessive dietary salt ingestion, chronic kidney disease, diabetes, and left ventricular hypertrophy, female sex. When somebody has these factors, you can be careful. They'll be going for resistant hypertension. Older age, aortic stiffness, risk factors and comorbidities. So when somebody, old person comes, you must be very careful and see whether hypertension is controlled. They are the candidates going for resistant hypertension. And then if the initial BP, when they come, even the first BP check is 195, 104, that means these people also have chances of going for resistant hypertension or difficult to treat hypertension. And of course, the abdominal obesity, of course, I always insist in the, instead of, you must have stethoscope, also tape, measure the hip, 90 centimeters in South Asian and men and 80 centimeters in women. You know, the mid-abdominal obesity and obesity, normally we think the abdominal obesity is the godown. It is not godown, it is a factory where so many things are happening. Adiponectin is one of the good hormone that is not, that be reduced in the adiposity. All the inflammatory marks are there. Insulin resistance, you know how insulin resistance can hypertension, and then how kidney can be a cause. There will be tuberoindustrial fibrosis, podocyte injury, then altered tubuloglomerular feedback, decreased natriuresis. All these things are due to obesity, can lead to hypertension. Then diabetes, there are 4 mechanisms one should remember. One is diabetic nephropathy, insulin resistance, volume expansion, and blood vessel changes. Blood vessel changes in all 3 vessels like Cushion artery, conduit artery, and microvascular artery. Cushion artery is a big artery like aorta, where atherosclerosis happens, that is ISH, isolated systolic hypertension. Conduit artery is the artery which supplies the organ, kidney, brain and all. That atherosclerosis, intima thickness, that is organ ischemia. And microvascular dysfunction, organ ischemia. All these things are the causes for, or the mechanisms why a diabetic patient develops hypertension. And then LVH, left ventricular hypertrophy, it is a cause of the hypertension. And also once you have left ventricular hypertrophy, left atrial pressure is more, and these people are more prone to develop more pressure, and then it can lead to resistant hypertension. So LVH is the cause and the effect of resistant hypertension. Now, salt, last time we were talking elaborately on salt. All of you know about the hemodynamic effect, why salt produces hypertension. Don't forget the immune system, that modulation of T cell, T helper cells, and Tregs also can produce endothelial dysfunction, impairment of pressure natriuresis, and produces hypertension. Then comes the kidney. The kidney can lead to hypertension because of sodium retention, nephron loss, ischemia, activation of renin-angiotensin aldosterone system, fluid overload, vessel diameter, and vessel stiffness. You know, blood pressure is cardiac output into total peripheral resistance. So fluid overload is increased, cardiac output is increased, vessel diameter and vessel stiffness causes increased peripheral resistance. So the blood pressure is increased in kidney damage. Now the drugs, there are a lot of mnemonics, I think Rajshekhar will tell you. And recently Chennipan was saying, drop it or crop, whatever it is, you remember chronic kidney disease, obstructive sleep apnea, renal parenchymal disease, primary aldosteronism, renal artery stenosis. These are all the common. Uncommon is pheochromocytoma, Cushing, and hyperparathyroidism. Then, of course, again, mnemonics, A, B, C, D diagnosis of secondary hypertension. A for accuracy, apnea, aldosteronism. B is bruit in the kidney, when the autoitis and kidney blocks are bruit. Bad kidney, catecholamines, pheochromocytoma, coarctation, Cushing syndrome, drugs, diet, ethanol, erythropoietin, all these things are the causes for secondary hypertension. Then you must ask all the patients history. Again, first day we talk, even in hypertension in the modern days, clinical history, clinical examination is very important in spite of all gadgets. So you ask for non-narcotic analgesic, non-steroidal anti-inflammatory, sympathomimetic agents like decongestants, diet pills, cocaine, stimulants, alcohol, oral contraceptive, cyclosporine, erythropoietin, natural liquorice, and herbal compounds. These are the drugs which can cause hypertension. You must ask the history. Not only find out why they're taking, and you must also adjust the antihypertensive according to the drug what they take. And NSAID, I've already told you, renal-prostaglandin inhibitor, sodium water retention, acute kidney injury, blunting anti-hypertensive effects of almost all drugs except calcium blockers. That's what I said. When somebody is taking NSAID, ask them to stop. If you cannot stop, the best drug which will act as antihypertensive is calcium channel blocker. And this is obstructive sleep apnea. It can cause hypoxia, hypercapnia, arousal of intrathoracic pressure, sympathetic overactivity, fluid retention. And one important thing, during the nocturnal rostral redistribution from the legs during sleep, and there is an upper airway collapse during sleep. So that's why you get OSA. This is the mechanism. And coming to the female, I told you the risk factor for hypertension, resistant hypertension, female. Non-traditional risk factors like menopause, excessive weight gain, gestational diabetes, preeclampsia, premature delivery. These are all pregnancy adverse outcomes. You must always ask history whenever a lady comes, what is the pregnancy, whether there's any premature abortion, things like that. And of course, increased production of aldosterone and enhanced mineralocorticoid receptor signaling, aberrant estrogen signaling. And you must also find out obstructive sleep apnea, women underrepresented in clinical trials. And when they have OSA, CPAP therapy might not be benefit as like women. So all these things are the causes of why women get hypertension, resistant hypertension. Now the secondary hypertension, I'll just quickly go through. CKD, I'll tell you one clinical pointer and one basic investigation. When in CKD, you think refractory normocytic normochromic anemia, descending edema in CKD, and you do creatinine, EGFR, potassium, and ultrasound kidney. Renal artery stenosis, young hypertensive, flash acute pulmonary edema, and then renal artery Doppler and MR angio. Then OSA, daytime, the three symptoms are daytime sleepiness, nocturia, early morning headache. You do polysomnography. And then primary hyperaldosteronism, muscle weakness, unprovoked and provoked hypokalemia, plasma aldosterone renin ratio. Aortic coarctation, young claudication legs, brachiofemoral delay. You do echo, iotogram, and angiogram. And then pheochromocytoma, palpitation, sweating with hypertension. And then neurofibromatosis type 1. You do urinary fractionated metanephrines. Cushing's, buffalo humps, stria, typical external features, easy bruising. 24 hours urinary free cortisol. Hypothyroidism, bradycardia, constipation, hypertension. Do TSH, free T4, hyperthyroidism, tachycardia, hyperparathyroidism, stones, groans, and moans. Then primary hypertension also suddenly becomes control hypertension becomes resistant hypertension. And you must always think about atherosclerotic RA stenosis, renal artery stenosis. Or somebody has got hypertension, everything is under control, suddenly they have the thyroid disease, it becomes resistant. Hyperaldosteronism on the primary hypertension. CKD, erythropoietin, OSA, new habits, new drugs, gain in weight, peripheral vascular disease, new onset of endocrine disease, malignancy, chemotherapy, of course, now COVID. So somebody has got a primary hypertension, controlled hypertension suddenly becomes uncontrolled, you must rule out or think about these causes which can cause additional hypertension. Now, what are the basic investigations you do? Ambulatory blood pressure monitoring to rule out mask hypertension, weight coat hypertension, 12-lead ECG, echo, transbiotic echogram, complete blood count, serum glucose, urea, creatinine, plasma aldosterone concentration, renin, thyroid stimulating hormone, renal echo, renal artery duplex. Now coming to the management. Then, this is the same picture I have shown you last time also. In 1990, the TV was bulky, the person who is watching was thin. But in 2022, the TVs are very thin, the persons watching are the obese person. So you tell everyone, don't watch TV more than 2.5 hours, and you must do lifestyle modification and don't eat in front of the television. Because that is one reason why you develop obesity and hypertension. And apart from the walking aerobic exercise, 3 times a week, you can do dynamic resistant exercise. And then tranquility, either natural tranquility or induced tranquility. And sleep is very important. All of us should have a good sleep, meditation, yoga. These are the lifestyle modifications. Of course, the sodium, I already told you, 2,300 milligram, 111, 1 teaspoon. Now, we always say one peg. What is one peg for us? What is one peg for the person who is drinking? We must always monitor. Why always advise don't take alcohol? Alcohol gives the desire but takes away from the performance. Shakespeare said earlier. So I think whenever somebody asks the question whether they can take alcohol, though internet, everything we say alcohol 1 peg or 2 pegs every day is not harmful. But we always tell them they don't control with 1 peg. So I mean they don't stop with 1 peg. So advise not to take alcohol. Then the CKD management in primary care, lifestyle advice, exercise, smoking cessation, aim for blood pressure less than 130/80, offer IRB if ACR is more than 3 millimole, watch for creatinine, watch for EGFR, offer statins, offer antiplatelet drugs, secondary cardiovascular prevention, avoid non-steroidal anti-inflammatory drugs and drugs which can cause kidney injury. And then indications for endovascular procedures, the presence of a lesion is not necessary for indication. So just because somebody has got renal artery stenosis, you need not intervene. The only clear indication for intervention is refractory hypertension, progression of renal dysfunction, and recurrent episodes of congestive heart failure. And significant BP response may not be assured even after the stunt. Especially atherosclerotic renal artery stenosis, the results are not good. At least fibromuscular dysplasia now are question. Younger people, stunting may be good. Then OSA treatment, when the apnea hyperpnea index is 15 or more, and then excessive daytime sleepiness, impaired cognition, documented hypertension, you can give them CPAP. And then COVID hypertension, it can be controlled hypertension, become uncontrolled, pseudo resistance may be there, resistant to refractory, all for the patient as well as doctor. So all of you know, we are talked about, I in fact coined a term called lockdown hypertension during COVID. Now the treatment of Cushing syndrome, primary aldosteronism, all treat the cause, they'll be better. And difficult to control hypertension, how do you manage? Now I come to the management. I told you, what is resistant hypertension? You give them 3 drugs and 1 drug to be diuretic and give them maximum tolerated dose and then rule out pseudo resistance. Once you rule out all that and the person comes to you with 2 resistant hypertension, tell us how to go about. So Now, this is the way you should go. Persistent volume expansion. Whether or not it is sufficient to produce detectable peripheral edema, this contributes to resistant hypertension, even among patients treated with conventional dose of thiazide type of diuretic. Thiazide can be changed to chlorthalidone or indapamide if the eGFR is more than 30 ml. If the patient with eGFR is less than 30 ml, then you switch over to loop diuretics. If such patients are already taking a loop diuretic, then intensify the loop diuretic dose unless the patient develops signs of hypovolemia. Furosemide, always taken twice daily, torsemide once daily. Effective diuretic use is almost always necessary to achieve blood pressure control in patients with hypertension. I already told you resistant hypertension, the basic pathology is hypervolemia, whereas in the refractory hypertension, it is sympathetic overactivity. You know how aldosterone causes problems. Renin-angiotensin activation, potassium can breed aldosterone. The response is potassium loss, sodium retention, magnesium loss, PAI increase, pro-inflammatory markers, and then marked fibrosis and remodeling leads to hypertension, renal failure. So progression of renal disease, heart failure, and endothelial dysfunction because of the aldosterone. So what is the logic? So you must give aldosterone antagonist for the resistant hypertension. In a patient with resistant hypertension, an uncontrolled blood pressure, despite potent diuretic therapy, add a mineralocorticoid receptor antagonist. So mineralocorticoid receptor antagonists are spironolactone and eplerenone, 25 to 50 milligram a day. A potassium-sparing diuretic, amiloride or triamterene, is an alternative if a mineralocorticoid receptor antagonist cannot be used. Unfortunately, amiloride as a single mono drug is not available, only it's in the combination available in India. The risk of adverse effects such as gynecomastia, breast tenderness, and erectile dysfunction increases with higher dose of spironolactone, where eplerenone may be preferable. So, if somebody develops spironolactone is a very good drug, and if the side effects are more, you can switch over to eplerenone, or recently we have got finerenone. I'll come to it later. The serum potassium should be measured 2 to 4 weeks initiation of the titration of mineralocorticoid receptor antagonist, especially when the potassium is high normal range. You must monitor potassium, and especially when somebody takes ACE inhibitor ARB with chronic disease, monitor potassium. If the potassium is more, we'll have to switch over to some other drug. Of course, now the newer drug has come known, even SGLT is better. Ideal candidate is the one who's borderline hypokalemia in spite of ACE and ARB. That's these the ideal candidate to start spironolactone. And how do you take the fifth drug? There is little evidence to help guide the choice of the fifth drug. As an example, those with faster heart rate, that is more than 70 beats per minute, may benefit from adding a beta blocker, especially vasodilating beta blocker such as labetalol, carvedilol, or nebivolol. They provide antihypertensive benefit with fewer side effects compared with traditional beta blockers, particularly when high doses are used. This is the algorithm you must remember. First, I told you, optimize diuretic therapy. In a resistant hypertension, try to optimize diuretic dose. Then how do you add the fourth drug? You add spironolactone. Easily you can give if the potassium is less than 4.5. And you add beta blocker if the heart rate is more than 70, vasodilatory beta blocker. If the potassium is more than 4.5 and the heart rate is less than 60, you add alpha blocker. If the heart rate is more than 70, in spite of beta blocker, you can use clonidine or moxonidine. And even blood pressure is not under control, 6th or 7th drug you can use as direct vasodilator. Centrally acting agents that lower sympathetic activity may also affect you, but adverse effects are more common, like somnolence, dry mouth, and high quality data to support their use are lacking. So potential choices include clonidine, taken 2 to 3 times per day. Even clonidine dermal patch is available, or moxonidine. Moxonidine may have less side effects, but it is contraindicated in heart failure. Both can produce bradycardia. You must be very careful. Should be careful in combining with beta blocker, with moxonidine or clonidine. The other medication options include alpha-1 antagonists such as doxorubicin or direct vasodilators, hydralazine or minoxidil. The direct vasodilators, hydralazine and minoxidil are generally reserved for patients who remain hypertensive despite trying the other approaches previously listed. Fluid retention and tachycardia are common side effects, and loop diuretics are often needed to control hypervolemia when you use these drugs. Minoxidil is an excellent drug for a person who is hypertension, who has not responded with 3 or 4 drugs, and who is bald, and because it can cause hirsutism, which may be a particular problem in women. Then what is new in hypertension? The development of the drug pribostat in the treatment of hypertension continues. It is the first in a new therapeutic class targeting the brain-renin-angiotensin system controlled by angiotensin 3, a peptide that in various hypertension models exerts a stimulating effect of blood pressure via 3 mechanisms. It is called brain aminopeptidase A inhibitor. Useful where ACE or ARB not effective, like obese, blacks, and low renin hypertension and resistant hypertension. I'll show you another slide. This is called brain RAS, aminopeptidase A, aminopeptidase N inhibitors. Brain angio 3 in the control of group. New targets to treat hypertension. Brain penetrating API inhibitor. Pro-drugs as centrally acting antihypertensive drugs are now evaluated. Then this is the algorithm. You know, angiotensin 1, angiotensinogen, angiotensin 1, 2. And then through the ACE2, angiotensin 1 to 7, mass receptor, you would have heard about this, you would have known in the previous talks. And angiotensin 3, and this is APN. This APN is the aminopeptidase A, and then angiotensin 4 leads to insulin regulated aminopeptidase. So these are the mechanisms of how the newer drugs are acting. Now, the advantages of SGLT as a hypertensive drug. Various combination therapies in the management of hypertension in the SGLT. Recently, in the paper have come, many people are using SGLT. Empagliflozin for patients with presumed resistant hypertension. A post hoc analysis of the EMBARK trial. It also proves in the new article. Then combination of finerenone and empagliflozin in the model of hypertension-induced end-organ damage. This is again 2021 Nephrology, American Journal of Nephrology, the patient-oriented translational research article. And then what is finerenone? I think everybody should know what is finerenone because it's a new drug. Now, good thing it is available in India. Finerenone is a 3rd generation of mineralocorticoid receptor antagonist, a potent, selective, non-steroidal mineralocorticoid receptor antagonist that targets fibrosis and inflammation by blocking overactivation of the mineralocorticoid in the kidneys and heart. It is also in the heart compared to other drugs. I'll come to comparison. The selectivity and the greater binding affinity of finerenone to the MR may reduce the risk of hyperkalemia and renal dysfunction, and thereby overcome the reluctance to start and uptitrate MRAs in patients with heart failure and diabetic kidney disease. So compared to the steroidal mineralocortical antagonists, spironolactone and eplerenone can significantly improve the prognosis and the quality of life patients with heart failure, reduce hospitalization and mortality. However, due to the low selectivity, the classic mineralocortical antagonists may lead to elevated serum potassium, development of male breast, female menstrual disorder, and other adverse effects. This is the comparison: spironolactone, eplerenone, and finerenone. Because you must know practically, we'll have to, when you do practice, you must know when to give spironolactone, when to give eplerenone, when to give finerenone, because you may come across resistant hypertension. For a resistant hypertension, aldosterone antagonist is very important, and normally you can choose easily spironolactone. If the potassium is normal or if potassium is less, you can use. If the potassium is high, then you think about finerenone, which can be used safely. And then in a diabetic kidney disease, where the hypertension, finerenone scores over good, and finerenone and SGLT combination is useful in resistant hypertension. Of course, potency is spironolactone high, and then finerenone high. Selectivity low, high, and important thing in tissue distribution, kidneys are more in the heart, more than heart, 6-fold increase. Whereas eplerenone, kidneys are more 3-fold high than the heart, whereas in finerenone, equal both in kidney and heart. That is why it is the preferred drug. Then sacubitril valsartan as a treatment for apparent resistant hypertension in patients with heart failure and preserved ejection fraction. This is from the ESC new paper, which says the combination can be also used in resistant hypertension. And this is how, because of the combination, you get a decreased aldosterone, diuresis, natriuresis, inhibited sympathetic tone, decreased hypertrophy, and improved insulin sensitivity. So that's why this combination now being tried in resistant hypertension. Now, last week, somebody asked me, what is de-escalation? How do you de-escalate? If the BP is consistently at target, de-escalation may be done. Again, you must monitor. You should not de-escalate and leave. You must monitor whether the pressure is maintained. The principle of the de-escalation is to reduce or stop BP reducing drugs rather than BP and clinical event reducing drugs. So what is meant by BP reducing drugs or clinical event reducing drugs? For example, in a coronary artery disease, when the patient is on beta blocker, ACE inhibitor, and CCB, you can reduce CCB, which is a BP reducing drug, but don't reduce beta blocker, ACE inhibitor, which is the clinical event reducing drug. In CKD, ARB and ACB, ACE inhibitor are the clinical event reducing agent. In stroke, amlodipine and ACE inhibitor. In heart failure, beta blocker and ACE inhibitor. In diabetes and ACE ARB. So whenever you want to de-escalate, you must do de-escalate step by step, monitor frequently, and then don't reduce even reducing drugs. These drugs are given not to reduce the blood pressure, but to reduce the clinical events. Hope I'm clear. Now, these are the ways how renal signals to the brain. And you know what is renal sympathetic denervation. When you denervate afferent nerve, increase the renal flow, reduce the sodium retention, renin secretion decrease. And when they cut the afferent nerve fiber, central sympathetic activity is reduced. These are the trials which they have done, and unfortunately, not the other previous trials are effective. Now, recently, Simplicity 3 trial and Spiral HN and Radiance trial shows some improvement, and people use renal denervation for refractory hypertension. And again, this is the cardiac neuromodulation therapy, where arterial lead, implantation pulse generator, and then this is electrical baroreflex activation therapy, endovascular baroreflex amplification therapy, transvenous carotid body ablation. These are the baroreflex or stimulation therapy. And then renal denervation can be radiofrequency based renal, ultrasound based renal denervation, or alcohol mediated. And this is central iliac arteriovenous coupler. These are the devices where you can reduce the blood pressure when you cannot reduce the blood pressure by drugs, when there is a refractory hypertension. And the difference between carotid baroreflex activation and renal denervation, 35 mm reduction in systolic blood pressure for 1 year, whereas 30 to 12 millimeter in the renal denervation. The durable results in the renal denervation is up to 24 months. Device implant, significant local complications are there in baroreceptor activation. The device-based therapies in 2018 ESC guidelines says not recommended unless in the context of clinical studies and RCTs until further evidence regarding the safety and efficacy becomes available. This is the overall pathology. Drug-resistant hypertension is due to arterial stiffness, endothelial dysfunction, sympathetic nervous system, and sodium volume. The sodium volume concept is resistant hypertension. Sympathetic nervous system is refractory. So you get obesity, sleep apnea, aldosterone, vascular calcification, blood pressure, poor blood pressure control, diabetes, chronic kidney disease, drugs, inflammation, aging, and obesity. Again, this cycle. So this is the understanding of resistant hypertension. And this is a difficult to treat hypertension. I tell you mnemonics. C for compliance, A for alcohol and apnea, R for reluctant physician, that is inertia, diet, salt, and diabetes mellitus, I for interfering substance like NSAID, O for obesity, metabolic syndrome, L for lower limb pulses, coarctation, peripheral vascular disease, other secondary causes, chronic kidney disease, renal stenosis, and good technique. If you don't have a good technique, again, if you get pseudo resistance, and last is U, white coat hypertension. So this is called cardiology. If you remember the cardiology, the difficulty is made easy. The cardiology, the compliance, adherence, alcohol, apnea, reluctant physician or inertia, diet and salt, interfering substance, obesity, coarctation, lower limb pulse, other secondary causes, good technique, and white coat hypertension. If you remember this, you will remember resistant hypertension. The difficulty is made easy. So, ladies and gentlemen, I always quote this slide: control over diet, takes regular exercise, has time to relax, does the right toil in discharge of his duties, observes proper hours of sleep and awakening, and is balanced in his actions, reactions, emotions, and reasons and duties, rewards, conquers disease, from Bhagavad Gita. So now I think With this, I will stop and I'll stop sharing. Now, I request Dr. Jain Panda to conduct the Kahoot. The technical team will project the Kahoot. So, over to you, Jain Panda. Thank you.
Great presentation. Please give a big hand. And this is listening from the master directly. You have seen the pictures. You have seen how lucid was the presentation, and it contains from the beginning to the end of the subject. Not only that you have diagnosed, not only you have classified, not only you have that controlled the blood pressure, but keeping all other aspects like complications and the further outcome, and then putting it in a philanthropic way with a very pictorial and cartoons. It makes very interesting. So I congratulate Dr. Muruganathan for another master presentation, and we have more than 200 people at different point of time listening, and many more in the Facebook and the social media, and I'm sure you have taken the best out of it. So this Kahoot quiz is based on the presentation facts of Dr. Muruganathan. So those who have listened will attempt, and I request to note the game pin. This is 3552015. I'm repeating 3552015. You have to join at www.kahoot.in and with the Kahoot app. So we see more than 10 people, 12 people, 13 people are joining, and we have questions also which have come to the question answer box, and I'm sure we'll have a good panel discussion with Dr. Rajshekhar and Dr. Bidita and Dr. Shangram and all team who are here. And let us first watch this very interesting session of Kahoot quiz. And those who have fully the different facts, and the questions are mostly based on the presentation, and you can attempt and get good prizes, and this will give you a reward of knowledge regarding hypertension. So let us keep it open till more people join, and then we'll go to the questions.
In fact, Jayant, I'm very happy to tell you one Hemant. You see the Hemant. Yeah. Always, whenever we use Kahoot, he will be the first person. I don't know how he joins. He'll be the first person out of 100 quick Kahoot. 90 times Hemant only the first person. And one pleasant surprise when I went to Ahmedabad, I met him during the breakfast. He came and introduced himself that he's the Hemant. And he brought, he showed his wife also.
He's the Kahoot participant.
But I saw him only live on that day in Ahmedabad. So I was really thrilled and excited. Same way, Hemant also was very happy.
I congratulate Mr. Hemant. And then this is very interesting that he takes so much of interest in our presentations, participates first to join, and wins the first prize. So congratulations, Hemant. I'm sure you'll also score good this time. We have 44 participants by now, and then still more are joining.
I think we'll stop in another 2 seconds, Jayanto, because
so it will reach 50 participants. Should we stop, sir, or we'll go further?
We'll go far. We'll go now. We'll start now. Yeah.
So Masterclass Webinar Series 2, Difficult to Treat Hypertension. Countdown begins. Quiz. Question for you.
You read the question.
The first comes, the difficult to control hypertension are uncontrolled hypertension, pseudo-resistant hypertension, approach-resistant hypertension, and all the above. So,
the correct answer is all the above.
Correct answer is all the above. And Dr. Sundar Pandi has scored the highest mark. What are the protective measures to be taken to control hypertension? A, reduction in physicians' inertia. B, diet and physical activity. C, regular patient follow-up with BP measurement and counseling. D, the improvement in patient adherence, and all of the above.
Oh,
We had
all the
37
37,
participants had
100% result.
yeah,
All,
yeah. All have answered the right answer, and right answer is all the above, and all have corrected.
that shows I'm happy that people listened and then did this.
And these are the best 5 participants, and you see the score. Which pharmacologic agent can increase blood pressure and contribute to drug-induced resistant hypertension? Non-steroidal anti-inflammatory agents, oral contraceptives and hormone replacement, immunosuppressive agents, all of the above.
Again, 37.
So again,
right.
the answer is all of the above. And we have Harsh is the topper at this point of time. Which is the most frequent complication of apparent resistant hypertension? Heart failure, ischemic heart disease, cerebrovascular accident, cardiac mortality. Very high number of people have attempted, almost 46 answers, and the answer is heart failure. And again, the topper now is Rekha. Pseudo-resistant hypertension causes include all except the faulty technique, the physician inertia, home BP monitoring, non-adherence. Which gives you the pseudo-resistant hypertension?
Except.
Yeah, all except. So it was again a tough round. In white coat hypertension, the HMOD is absent, present, don't know.
Yes.
It's absent.
If it is,
most of
white coat hypertension, HMOD is absent. In a mass hypertension, you will have HMOD.
Yeah. So now Manish has topped the list. Osler's maneuver is done in young patients, old patients. The answer is old patients. And again, at this juncture, Manish is the topper. Which are the following groups likely to have true resistant hypertension? Son-in-law and father-in-law, daughter-in-law and mother-in-law, and both A and B. True resistant hypertension.
Yeah, why this is just a jovial question. I told you women stands more chance of getting resistant hypertension. So women as a gender. So
yeah, women as a gender comes, and daughter-in-law and mother-in-law comes at the answer.
yes. Just for fun, I introduced like that.
So again, Manish is the topper. Obesity causes resistant hypertension by following except endothelial dysfunction, insulin resistance, increased parasympathetic activity, and leptin. It's increased parasympathetic activity, and most of the people have done correct by attempting this. Again, Manish has topped the list. The duration of TV watching per day is limited to how many hours? 4, 2.5, 3.5, 24. Those who want to watch more will like to ensure the D. Yes, the answer is B. It's 2.5, and most of the people have corrected, around 39 people. And again, Manish at the top. Refractory hypertension is defined by using how many drugs? More than or equal to 3, more than or equal to 4, more than or equal to 5, more than or equal to 6. More than or equal to 5, and most of them have answered, and Rekha again become the topper. The most important drug in the treatment of resistant hypertension is alpha blocker, aldosterone antagonist, clonidine, or beta blocker. The aldosterone antagonist is the answer, and again, many of you have answered this. And here also, Rekha is the topper. What are the ideas help to improve BP control involving the private sector? It's opportunistic screening, self blood pressure monitoring, and blood pressure monitoring in public places, follow-up, or hypertension clinic in villages. All of the above. 5 bits for you. Obviously, the answer is all of the above, and most of people have attempted.
The reason why I put this question, I want all the private sector also to be actively involved in the hypertension management.
Sir. So the third is Dr. M.I. Hassan. Second is Manish Sirshat. And the first is Rekha T. Congratulations, winners. This is a masterclass webinar series to difficult to treat hypertension. Kahoot quiz results. And Rekha has topped the list with 11,008 points. Manish Sirshat is second with 10,965. And Dr. M.I. Hassan is third with 10,464. And they are all scored very nearby rank and done very good. Congratulations.
And they'll be getting this BP monitor. I request everyone to send the courier address with the PIN code and also with the mobile number. And Hemant unfortunately became fourth only. Try next time, Hemant. Now over to you for your discussions. Go ahead, Jay.
And now we'll go to the panel discussion.
Yes.
I invite Dr. Rajshekhar, our panelist, and we have very interesting questions in the question answer box. And I'm sure you'll ask more questions by the time the questions are answered. I request Dr. Rajshekhar, Dr. Muruganathan to take up the questions.
Okay.
You ask the questions, Jayanto.
Yeah. What about centrally acting drugs like clonidine and moxone? Already you have told, sir.
Yeah, actually clonidine and moxonidine comes only after 4 drugs. And if the person has got tachycardia, and if the beta blocker is some or other not indicated, we can give clonidine or moxonidine. The side effects of the clonidine is more than the moxonidine, but you must use carefully moxonidine because in heart failure, you should not use this. So this is centrally acting drugs. Clonidine also available in dermal patches. So it is only the resistant hypertension, and especially in a hypertensive urgency orally, when you want to give drugs, you can always try these drugs also. This is not coming as a first 3 line drugs, only 4th or 5th line. And when there is a tachycardia, clonidine can be given. When somebody has got a beta blocker, when you use clonidine, make sure they don't go for bradycardia.
Yeah, alpha antagonist. Moxonidine, centrally acting. Again, it is an imidazolone receptor antagonist. Yes, next, do SGLT2 inhibitors help in reduction of BP? Yes, it will reduce. But as it is, we don't use as a, when it is associated with heart failure, CKD. As it is not a first drug, definitely it reduces. One of the advantages of non-glycemic benefits of gliflozin is BP reduction and also lipid profile reduction. Yes, sir, your comment.
Jayant, you please. Okay.
Yeah.
See, now I showed you a picture. I showed you an article where they tried SGLT as an anti-hypertensive in many races, including Asia, and they showed quite good, like 4 to 5 millimeters reduction is there, especially in the diabetic hypertension. When somebody has got diabetes, SGLT can be handy, and SGLT plus finerenone combination is very good for resistant hypertension because you need not worry about potassium, because SGLT and finerenone will take care of the potassium more potassium. If there is more potassium also, they can be given safely. And there is a recent article which I showed you, finerenone and SGLT combination they used in resistant hypertension.
Yeah.
Finerenone is a it's a mineralocorticoid receptor antagonist. It's a non-steroidal structure. It is available as Carandia. It is FDA approved. Yeah, it is very good. Somebody is talking.
Just Dr. Shangram, please mute yourself.
Mute. You mute.
You mute Dr. Shangram.
Yes.
And SGLT, this
OCPL, sir. OCPL.
No, not OCPL. Not it. We have not finished this finerenone.
Yeah. Sure.
Finerenone is a non-steroidal mineralocorticoid, so it does not have the gynecomastia and impotence and the loss of libido, not common in finerenone. That's
and one more advantage of finerenone, Rashega, it is more for cardiac as well as kidney. Whereas spironolactone, most of them in kidney, 6-fold increase compared to heart. Whereas in finerenone, 1:1. That is why it is used for cardiac fibrosis and cardiac failure, and especially diabetic kidney disease. Finerenone is most widely used in US, and it is recently come to the Indian market also. And as I told you, finerenone, SGLT combination finerenone are being tried in very many resistant hypertension cases.
So next question is, so oral contraceptive pills and hormone replacement therapy in females important in hypertension. Yes, it goes without saying. Already sir has told one of the causes of resistant hypertension. Just remember by mnemonics: A, B, C, D, E, F, G, H. Finished. A for that is the ACE inhibitors. That is the A for that is anti-inflammatory drugs. That is non-steroidal anti-inflammatory drugs. Acetyl salicylic acid, aspirin, and biomodulators. B for biomodulators, that is cancer chemotherapy drugs, that is tacrolimus drugs we use, cyclosporin we use. So they are all causing resistance. A, B, C, yes, that is C for common salt, C for contraceptives, of course, oral contraceptives, C for and corticosteroids, and D for decongestants, that is heparin containing agents, nasal decongestants. E for erythropoietin, again resistant hypertension, and F for frequent ingestion of alcohol, already sir has told. F. G for ginseng, many people on the counter sales, Revital they take. H for herbal supplements, Huanhua, Chinese food and all. So these are all the causes for resistant hypertension. So next question will go.
Jayanto? You can also ask Jain.
Yeah. No. I'm asking panelist and the speaker. So the OCP and HRT in the female important in hypertension.
We have answered that question.
Yeah, and the other question from Amod Burkar comes: can administer sacubitril used in refractory hypertension in the absence of the heart failure?
Yes, sir.
Yeah, actually,
Sacubitril.
Only thing is the cost factor.
Actually, sacubitril now being used in the resistant hypertension. Yeah, RNA is now used in the resistant hypertension. I showed you an article where they were trying, but of course, not routinely we use because we have got enough drugs to counteract resistant hypertension. Sacubitril being costly, we don't use that. But recently, papers have come. Sacubitril also can be used. How sacubitril scores over the other drugs? There is a big data available. Of course, now we not started using it. We are using only for heart failure. Plus, in a resistant hypertension, it can be tried.
Yes, it
Yeah,
belongs to
actually, usually with sartans it's combined, and we have combination of valsartan and sacubitril available in the market, which we have used in the heart failure with reduced ejection fraction. Arni and valsartan helps our patients very much. And then if I'm sure that it will be more affordable and can be used in this indication also. Dr. Rajshekar.
Yes, that's why it is called the heart failure, the fantastic four. That is 4 drugs, BAMS, BAMS, B for beta blockers, A for RNA, angiotensin neprilysin inhibitors, B for mineralocorticoid receptor antagonist, S for SGLT2 inhibitors, that is gliflozin. So it bombs the heart failure. That is why it's called the fantastic four. There is a recent article last year published.
Yeah. So the Humayun Hassan has asked the dose of finerenone for hypertension.
Already Sir has told.
Yeah. And we have got the address of our third position winner in the cohort. An asymptomatic patient with BP of 180, 110. What drug should be started? Should any drug be given for immediate management? This is by Ramya Ravichandra. Dr. Muruganathan.
What is the question? Anybody, when somebody comes with blood pressure of 180, 110?
Yeah, asymptomatic.
Yeah, asymptomatic. Okay, even if it is asymptomatic, when the person has got 180, 110, you will have to recheck the pressure and then make him sit or relax for some time, check the pressure, and you must start 2 drugs, not 1 drug. When the blood pressure is more than 160, 100, it is always better to start 2 drugs. Don't wait for more time. You have to immediately start the treatment, and you always start with, depending on the individual, you can start with a calcium channel blocker or calcium channel blocker and the ARB combination. If they are female, reproducing age, you can start some other drug instead of ACE or ARB. Depending on the individual, depending on the comorbidity, depending on the situation, you must start. But don't leave the patient. You must see and then start the both the therapy. In fact, he may go in for hypertensive emergency if you leave him like this. That's why in India, normally we say in hypertensive urgency, no need to admit. But in our experience, we always admit even urgency because they may go for problems. In this particular patient, you must also rule out HMOD, hypertensive mediated organ damage. You must leave the fundus, any retinal changes, any albuminuria, any LVH, ECG wise or echo wise. So if they have secondary changes, that means the hypertension is quite long time, and definitely he needs good attention and good investigation and good follow-up.
Thank you, sir, for that appropriate answer to this question. We have another important question regarding precision medicine for hypertension from Dr. Geeta Arora. She has asked any role of this precision medicine in hypertension control.
Thank you, Geeta Arora. I think I have written a editorial in our MediBeats newsletter recently. Precision medicine is coming into practice even in diabetes, in everything. Precision medicine is like personalized medicine, though it is different. The precision medicine, depending on your environmental factors, depending on your genes, depending on your individual, the target is, the treatment is vary. So always it is good to analyze and then treat the patient according to the individual with all the biomics. We call it as biomics, proteomics, metromics, metabolomics. All these omics we will have to see, and then individually we treat. That is why it's called precision medicine. Always is good, but it is not possible and practical in a wider, longer range. And it takes time. But of course, it's good to have precision medicine and hypertension.
Dr. Rajendra Sharma has asked for renal protection in normotensive diabetic, any medicine. Patient is not having hypertension, but a case of type 2 diabetes.
In fact, Jayant Panda, you will be a better person to answer, but I tell you, we always give ACE inhibitor 2.5 milligram as a protective, because there are some articles how ACE inhibitor can protect somebody who is not having this one as a renal protection. So you can add more.
Low dose ACE inhibitors or ARB can be used for renal protection, correctly guided by sir. The edema in controlled isolated systolic hypertension in 85-year-old female, cause and treatment. So patient has isolated systolic lady of 85 years, edema. So Dr. Shalu Bhutani has asked.
Oh, Salu Bhutani, yeah, my good friend Salu Bhutani. When 85-year-old woman has got edema, you must first rule out what is the cause of edema. It can be heart failure edema. A person has got hypertensive heart failure, or it can be renal cause. It can be kidney, which can cause edema, or it can be drug. For example, if the patient takes calcium channel blocker, it can be there. So you must find out what is the cause of edema, and depending on the cause, we can treat. And if it is due to heart failure, of course, we can use diuretic. If it is due to amlodipine or calcium channel blocker, you can reduce the dose. If it is due to renal, then of course you can tackle renal. So this is how you have to approach the patient. But any isolated systolic hypertension should be treated, because in an elderly person, this is the problem. And as I said, you should rule out pseudo resistance also in a systolic hypertension. You do this oscillous maneuver, see whether the blood vessels are thickened, and it can be a cause of pseudo resistance in the elderly patient. What he has got, it may not be really hypertension. So these are the things you must do. If still the edema is there, it may be physiological, hypoproteinemia, dependent edema, so many causes of edema that we will rule out. And if the patient doesn't have breathlessness, and if there is no other comorbidities and symptoms, we can go step by step and treat the patient.
Right, sir. Because he is elderly, we have to be very careful and evaluate properly to know the cause and proceed. The Amod Borkar again has asked, reflex tachycardia due to calcium channel blockers, can it be reduced by nocturnal administration?
Somebody has got reflex tachycardia, whether you give nocturnally or daytime, the tachycardia, because of the drug, it cannot be reduced, because all the calcium channel blockers has got 24 hours action. So whether you give daytime or nighttime, it has got 24 hours action. In that case, you can change the calcium channel blocker into, there are 3 channels. So that a calcium channel blocker which does not have this N channel, which has N channel, it can be tried, like minidepine or cilindapine. They say the reflex tachycardia is less. And the reflex tachycardia also may be due to some other drugs also. You may have hyperthyroidism also. You will have to rule out. And if you want to change the calcium channel blocker, you can change that calcium channel blocker with 3 channels or 2 channels where the reflex tachycardia is less.
Reflex tachycardia, calcium channel blockers 2. One is dihydropyridine derivatives, another is non-dihydropyridine derivatives. For non-dihydropyridine derivatives, verapamil and diltiazem, we don't have reflex tachycardia, only it is used for tachycardia with hypertension, especially with the CKD, when other drugs are not indicated. So reflex tachycardia very common in nifedipine and amlodipine. There are 3 channels as Sir told LTN. So 3-channel blocker is benidipine and 2 channel blockers are cilnidipine and cilnidipine. These drugs L and T channel, many drugs dual channel blocker. So present L channel in the afferent arterioles, T channels in the afferent arterioles. Just remember L, A, T, E. L in A afferent, T in afferent arterioles, and N is neural receptors, N for neural, N for N. Finished. That's all. So accordingly, we can modulate the drugs. No problem.
Yes.
So
Very rightly
one
told.
doctor has asked the dose of fentanyl. That is the previous question. That is, his name is Humayun Hassan. The dose is available as Carandia is available as 10 milligram and 20 milligram. Single dose, maximum 20 milligram per day, according to the EGFR and potassium. Okay.
Yeah,
And,
yeah.
If the
And
EGFR,
Dr. Shankar has asked.
if the EGFR is less, you can reduce phenylidone dose also.
Yeah.
So that's how 10 and 20 currently. Okay.
Dr. Shankar has asked which aldosterone antagonist is better, spironolactone or eplerenone?
I already told you spironolactone is the commonly used drug. It is very effective. It is good. But only thing, if the patient has gynecomastia or sexual dysfunction and breast tenderness, we can switch over to eplerenone, because eplerenone is little costlier compared to spironolactone. And both spironolactone and eplerenone are steroidal mineralocorticoid antagonists. And if the potassium is more, both the drugs are not good. You should not give these drugs. There you can try eplerenone, because compared to these 2 drugs, they have less problems with potassium. That's why eplerenone nowadays is used in many kidney problems. They reduce cardiac fibrosis in cardiac cases. Only thing, the cost is more. Spironolactone is cheap and good, whereas eplerenone is a really good drug, but again, it's little costly without gynecomastia, without any side effects. So I've given you comparison of both all the 3 drugs in the tabular column. So depending on the situation, depending on the cost, depending on the conditions, we can use it.
Yeah, very clearly you have delineated, and that should help people. Dr. Rajshekhar.
Regarding spironolactone, eplerenone, though eplerenone is costly, spironolactone is cheaper, but the greatest advantage of spironolactone, that is in resistant hypertension, 3 drugs. The 3rd drug is a diuretic. Even the patients are not responding, the 3rd drug is a diuretic. You can add spironolactone as a 4th drug, because I've been hooked.
You're not audible, sir.
Rajshekhar, you are not audible.
Now audible?
Yeah, audible.
Now, the spironolactone, it is a pannexin channel inhibitor. What is a pannexin channel? Pannexin channels are ubiquitously expressed in our body, that is in the smooth muscle and vascular endothelium. Whenever there is a pannexin channel is stimulated, there is a stimulation of adrenergic stimulation. Adrenergic stimulation causes in turn ATP release. That causes vasoconstriction, increase of BP. So if pannexin channels are inhibited, the adrenergic stimulation is prevented and ATP release is reduced. So instead of vasoconstriction, there is vasodilatation. So that is why spironolactone is a pannexin channel inhibitor. It is a very good drug as a 4th drug, even though there is a diuretic in 3 drugs in resistant hypertension. That is
it's a mineralocorticoid receptor antagonist, steroidal. One more good thing about spironolactone, in a person with obstructive sleep apnea, the spironolactone also reduces the upper nasopharyngeal edema. Because in one of the reasons why patient have obstructive apnea is because of the pharyngeal edema. So this drug also reduces the upper respiratory laryngeal edema. That is why spironolactone is better. Of course, as I told you, it is more in the kidney than the heart. So that is why the other drugs are better. I mean, other eplerenone is better in those situations where there is hyperkalemia and cardiac fibrosis, etc. But otherwise, normally spironolactone is good. And as you have said, after 3 drugs, spironolactone also can be added as a 4th drug. And then if many patients with this 4 drug combination, they get better.
So Dr. Ramesh Kumar Mahato has asked, 76-year female taking antihypertensive left some months back. She has stopped all the drugs. Present with chest pain and ECG shows ST elevation marker infarction and the blood pressure was 150/100. So in this ACS setup, is best for this patient.
No, actually, when somebody is on drug and if they stop the drug, especially if it is beta blocker,
Patient has a acute coronary syndrome.
that's what I'm coming to it. Whenever somebody takes a drug and they will stop the drug, especially they stop clonidine or beta blocker, if they are on that drug, there'll be rebound hypertension also. And anybody who has got hypertension uncontrolled, the commonest presentation will be cerebrovascular accident or myocardial infarction or kidney failure or epistaxis or retinal problem. So naturally, when somebody takes a medicine and if they stop, they are prone to develop all sorts of complications. When they have acute coronary syndrome, we'll have to treat the patient, admit the patient in ICU, whether he's fit for thrombolysis, whether he's fit for emergency angio, all that things you must do. And of course, you should also control the blood pressure. And when somebody has got a heart problem, best thing is, apart from other drugs, we should use also beta blocker if there is no contraindication.
Sure. Humayun Hassan has asked, how much BP reduction to be achieved in a patient of acute ischemic hemorrhagic stroke in emergency room?
Actually, in acute, it's a big subject by itself. If it is an acute hemorrhagic stroke, you should not reduce to more than 25 also. Though those days we used to say to reduce aggressively hemorrhagic stroke. Now they say don't reduce more than 25 MPa, and then reduce after 6 hours 160, 110, and after 24 hours you reduce. That's how you must do it. There is only 3 or 4 conditions where you reduce blood pressure in a dissecting aneurysm. You should reduce immediately. So in this case, as a acute hemorrhagic stroke, you should be very gradual, and you must always see, because if you reduce further, the cerebral perfusion may be reduced and you may have more problems. So for auto-regulation of the brain, you need the good blood pressure. If the blood pressure is suddenly reduced, the cerebral perfusion will be reduced.
Yeah.
So you must be very careful in those situations.
And the important thing is in ischemic stroke and all, once the patient comes to emergency room, the bladder will be full. First, you catheterize the bladder, then measure the BP. This is very important. One doctor has asked Sankar for resistant hypertension. Previous question. Already Sir has answered and we all discussed. RHTN, resistant hypertension.
That the spironolactone in connection to resistant hypertension, he has asked. Amod Borkar has again asked, what is the role of nitroprusside in hospital management?
Again, nitroprusside is used only in the hypertensive emergency. The one good thing about nitroprusside is a venous dilator.
Yeah.
So in acute emergency where there is parenteral administration required, we use beta blockers, we use nitroprusside, especially if they have cardiac problem. People try these drugs in as an emergency drug, IV drug. Nitroglycerin, nitroprusside are used in acute emergency cardiac problem. And if it is a hemorrhage, we use calcium channel blocker, nimidopine. So depending on the emergency of hypertension, we use various parenteral drugs. One of them is nitroprusside. It is a venous dilator.
So again, Sandeep Kumar has asked the role of SGLT2 inhibitor, the dapagliflozin, especially in CKD. I think we have discussed about the renoprotection and the hypertension reduction. Yusuf Hasnain has asked about a lady patient, 70-year, non-diabetic, whom he has kept on telmikind AIM, that's telmisartan and amlodipine, with a blood pressure of 170/70. He wants, I think, help how to go further with 2 drops. Yeah.
So simple. Add one diuretic.
So you just can add a diuretic and get a target blood pressure.
Yeah.
Actually, it's better to add chlorthalidone in a small dose and then see, and you can titrate the dose up to 12.5 or 25.
Yeah.
Because adding
Chlorthalidone is ideal.
chlorthalidone is ideal compared to chlorothiazide, and it is a long-acting drug. It has got other polymorphic activity also. It will be very useful if you use.
He has only asked, should I add third drug hydrochlorothiazide? But already it's answered, chlorthalidone. And there is a question: maximum tolerated dose of amlodipine, losartan, telmisartan, cilnidipine, and spironolactone.
Oh, he's asking full question. Okay. Amlodipine, we normally give only up to 10 milligram. We don't give 20 milligram, though the Western book says 20 milligrams is given. But in Indian setup, we give only up to 10 milligram. And telmisartan also, in our Indian experience, we give only up to 80 milligram. So it is always not advisable to increase the dose of one drug. You should always do a combination therapy, because doubling the drug, it may not double the effect of the pressure reduction. So always, you have optimum dose of amlodipine 10 and then telmisartan 80, and spironolactone up to 25 to 50, not more than 50 we use. And that means, all the other combinations you can try. And what is the other drug he said? Amlodipine, spironolactone?
Losartan, maximum 100 milligram.
Yeah. And losartan, again, you have to give twice a day. It is a 12-hour action drug. Yeah. You should not give once. You should be given 2 times.
Yeah. So last question again by Humayun Hassan. He wants a little clarity on your presentation regarding the calcium channel blockers issue related to pedal edema, where you have already told 3 receptors. So he wants to know which calcium channel blocker to be replaced for amlodipine and nifedipine, because it's a very common clinical problem every day.
The calcium channel blocker, it is produced, it does only arterial dilatation, whereas the ARB produces both arterial and venous dilatation. So if somebody has got edema, it is always wise not to change calcium channel blocker, add telmisartan or ARB. And both the drugs can, as a combination therapy, more effective, more potent and good. You need not change the calcium channel blocker just because of edema. You can try telmisartan or ARB and do it. Suppose if you want to change the calcium channel blocker, as Raj already said, you go for acylindipine or viridipine, where the edema is less. But theoretically, it is less. But even there, edema may be there. So it's always worthwhile to try ARB along with calcium channel blocker, rather than changing the calcium channel blocker into acylindipine or viridipine.
Yeah, that already you discussed. So by the time another question has come, last question: any role of sedatives and hypnotics?
Well, again, I told you lifestyle modification. One should have a calm, quiet sleep. If they cannot get, if they are very anxious, if they have anxiety and all that, you can choose drugs which are not addictive drugs, and like lifestyle modification, yoga and the meditation can be done. And those cases where there is a lot of anxiety and then behavioral and other problems, we can use hypnotics to make them serene, calm. Otherwise, routinely, we don't use sedatives. Depending on the individual, depending on the type of personality, we use the hypnotics or sedatives.
So we had a very informative session, and many questions have come from our attendees, and still questions are pouring in. Another question has come regarding advantage of telmisartan over olmesartan. I think the discussion was very clear and informative, and because it's time, we have to stop, and then rest of the
telmisartan, we will complete it. Telmisartan is the most lipophilic drug, and also Sir has already told last class, it is also has got a role on PPR gamma agonist. But the problem is it causes the myotoxicity, the disadvantage. 1 plus 1 minus, whereas olmesartan is the least lipophilic drug. These are the 2 differences, and it is also the cell receptor activity also, they differ.
And also telmisartan is also useful in Alzheimer's disease because it crosses the brain barrier. And the more clinical trials have come for telmisartan. But olmesartan is antihypertensive. As antihypertensive, the effect is like telmisartan only. And only because of the two actions, BPR gamma active, we prefer telmisartan, and the combination works well, and it is more well known in the many trials. That's why we use telmisartan.
A drug which is lipophilic will cross blood-brain barrier.
And
That is why the beta blockers, yes, that is why the beta blockers, bisoprolol and metoprolol, nebivolol, they are all lipophilic drugs, cross blood-brain barrier, prevent sudden cardiac death. Those are the advantages of these three beta blockers.
Yeah. So very important topic of resistant hypertension, very lucid presentation by the master teacher, Professor Dr. A. Muruganathan, and then the attendees are still more than 110 at the dead end of the day, and then Dr. Rajshekhar has done a marvelous work aiding the facts to Dr. Muruganathan's answers and presentations. So I must thank both the master teachers, Dr. Muruganathan and Dr. Rajshekhar, for this clarity and then leading the whole lot of attendees on a very important topic on this second session. I must thank all the attendees for taking interest and till midnight waiting and listening the discussions, and all who participated in the Kahoot quiz and who won the prizes. I must congratulate them. They have given their address in the question answer box. I request Megha to collect the addresses so that we can send them the prizes. And with this, I hand over the session to the organizers, thanking for such a wonderful opportunity for me to moderate this session. Thank you all.
Thank you, James, for wonderful moderation. And we will all meet on 17th and 18th on the World Medical Academy annual conference, where we are discussing a lot of interesting topics. More than 15 international speakers and 15 national important speakers like Nageswar Reddy, Sarin, Talwar, and so many other people are there. So it will be interesting to be there. Very easy time, between 2 p.m. to 7 p.m. on Saturday, and 9 a.m. to 1 p.m. on Sunday. So leisurely you can watch the speakers or stalwarts, and definitely it will be very useful in overall general medicine. We are talking about lipids, we are talking about hypertension, we are talking about diabetes and antibiotics, etc. So please join us. And today I'm very happy. People are asking all sorts of questions in the general hypertension. That means people are very much interested. So any number of hypertension webinars will be useful for all the practitioners. So my message is have a good accurate BP measurement, validated BP monitors, have 3 different cup sizes, look for adherence, don't have inertia, proper follow simplified protocol, spend some time for advising lifestyle modification, and spread the message so that we love hypertension-free India, hypertension-free world. And when you control hypertension, the disability is reduced and the people will live longer without much problems. Thank you for all your attention area, and thank Rajshekhar. I thank Sangram Radar and Megha for all coordination. And Vidita also I must thank, because Vidita was there in the beginning. I think she just left. So all of you, thank you very much. Good night. You. Bye.
Yeah. And hope Megha will send certificates to all.
Yeah.
Yes,
With the spelling correctly.
Yes, sir.
So the only one
you.
drug we have left, the maximum dose is cilnidipine 20 milligram per day, should not exceed that. With that we will conclude.
Yeah.
Okay.
Thank you.
Thank you, sir. Thank you.
Thank
Very
you.
nice
Thank
time.
you, sir.
Thanks. Thank you.